figure out how you can utilize the resource. So thank you guys for presenting today, and I'll turn it over to you.
Sounds good. Yeah, thanks everyone for helping organize this. So as Lisa mentioned, I'm part of the Northwestern University slash the University of Southern California Center. And so my name is Eunji Chung, and I'm from USC. I'm a faculty in biomedical engineering, and we have a very high interest in kidney nanomedicine and targeted drug delivery. And I'll start off by presenting some of our center's capabilities and kind of give a big overview of the center related to nanotechnology. And then I'm going to hand it over to my graduate student, Joshua Giblin, who is here. And he's going to kind of give vignettes and different kind of stories that will highlight some of these capabilities so you can get kind of an idea and a flavor of how you can utilize potentially your drug or your needs and combine that with nanotechnology and allow for kind of a targeted drug delivery system, particularly for kidney disease. Okay, so Josh, would you advance to the next slide? Thank you. Okay, so just to give a high-level background and introduction, the challenge is that traditional methods in kidney research are not able to allow for targeting to specific kidney tissues or cell types. And so when we leverage nanotechnology, just the way that it's been leveraged in cancer medicine, we can allow for a more targeted system, and it can allow for this platform to incorporate a variety of different cargoes, small RNAs, small molecule drugs. And of course, in more recent years, we've been able to show on a global scale that if you can package mRNA into nanoparticles and provide a new vaccine technology, and that's for COVID. And so kind of going back to our aims, the goal for our center is to kind of present and provide these technologies for the kidney space, which hasn't had that much nanomedicine and advances. And so with our expertise, we can provide these services. And so we want to provide robust, ready-to-order nanotech services to kidney researchers that want to leverage these advances. And then we want to, of course, enhance therapeutic outcomes. And so the importance and benefits of nanomedicine in general is that by packaging that cargo into a carrier system, you can first, not allow for degradation of that cargo because our bodies are also really good at taking those up and sequestering them and clearing them. But you can allow for it to stay in the body longer so the pharmacokinetic properties can be enhanced. And through that, you can allow for enhanced efficacy, improved safety profiles, precise targeting to a specific location, cell type of interest. And also you can optimize the dose response and the dose loading. And so not only can it be used for therapeutic purposes, but you can also use them for diagnostic and imaging and personalized medicine. And so just kind of our current gap in the kidney space is that it's being underutilized, nanomedicine in general. And so we can provide that expertise and marry that if you have like a drug of interest, but getting to the kidneys is quite challenging, we can allow for that combination. Okay, so some of the expertise, and of course, I'm part of this, as well as Chad Merkin, who is part of the International Institute for Nanotechnology at Northwestern, and I am the director of the Transformative Center for Nanomedicine and Drug Delivery at USC. And of course, there are many people underneath, including Josh, who is really, truly kind of becoming a PKD nanomedicine leader in the field, as well as for other kidney diseases in general. And so we can leverage these resources and expertise that exist between the two institutions. And so we can allow for this precision targeting for specific renal cell populations. And we can allow that for, by leveraging kind of the West and the Midwest, we have this kind of national reach through this consortia. So just to kind of give a little bit more nitty-gritty on the services, just on the left side, I've listed, the different services, kind of breaking down kind of more general ways, but these are kind of the categories that it falls under. We can identify molecular targets. So we can think about, in that disease setting, in that kidney disease setting, which target will be beneficial for us to design a nanoparticle for, so it can selectively get targeted there. We also have to think about the nanocarrier selection too. There are different types of nanoparticles and they have different pharmacokinetics. They also have different advantages and disadvantages. Some are more beneficial, for instance, for more hydrophobic drugs versus hydrophilic drugs. So there's a lot of this consultation and design that is needed in the beginning, because we don't want to put it in the wrong carrier. And oftentimes what happens, it can get sequestered in the liver. So that is something that we're always trying to kind of sway away from, of course, and we want to do kidney targeting. So there's a bit of optimization there as well. We also do the synthesis and coupling of that targeting moiety to the nanoparticle. We also characterize the nanoformulation. We have to think about stability, the size, the drug release, and we load the therapeutic payload into the nanoparticle. We want to make sure that's stable. The drug release rate is what is required or desired for the application of interest. And we can also test that this strategy is effective in vitro. And we can also do some consultation regarding how you might want to go about an in vivo application. And so on the right side, it just shows kind of our kind of workflow, as well as kind of our decision tree. And then on the bottom, it just kind of gives you an example of all the different nanoparticles that are out there and that we can offer through our center. So if you want more information, this is just kind of where you can get a bit more information. We've listed the Northwestern Hub, our lab website, as well as UAB, OKRA, and there's a QR code there. And there is a consultation request form that's out there. And so you can just kind of plug in the information and the things that you would like to do, and so we'll get it on our end, and then we'll figure out who would be the best person and what service it would make sense, and so we can provide a plan. So with that, let me introduce Josh, who is a second year graduate student in the biomedical engineering department at USC in my lab. And he has a handle on a variety of different kidney disease nanotherapeutics. And so he'll give, as I mentioned in the beginning, some different stories that can highlight some of the capabilities that I just mentioned for a couple of different applications.
Thank you, Dr. Chung, for your introduction. And before I get started, I just want to give a brief overview into our lab, what our nanomedicine research lab looks like, and what motivates us. So our lab really looks at certain applications, certain diseases, and uses the biology of the disease, as well as the physiology and anatomy of the target application. And that motivates us to design molecules. And through the design of these molecules, they become specific for their use case application. And this is just going to be something that you see over and over again throughout my presentation, is that we're using something from the disease to motivate our design, so that we increase the efficacy of our therapies. And it's just it's another thing. If anyone's interested in our lab website, the link is just in the left side of this slide here. One of the applications that our lab really focuses on is treating this disease called autosomal dominant polycystic kidney disease, or ADPKD. ADPKD currently affects about 1 in every 1,000 individuals, or about 12.5 million people worldwide, with 50% of patients developing kidney failure by the age of 60. ADPKD Sorry. ADPKD is generally characterized by the growth of large fluid-filled cysts in the kidneys. These cysts enlarge over time, which also causes the kidneys to enlarge. Thus, kidneys become extremely oversized, and as a result, the glomerular filtration rate, the GFR, also decreases, requiring patients to undergo intense dialysis towards their later stages in life. Currently, the only FDA-approved agent is tolvaptan. Tolvaptan has a modest therapeutic benefit. It delays the onset of end-stage renal disease on average by about 3.9 years, but it also comes with many unwanted side effects, some of which significantly impact the patient's lifestyle, and those include polyuria, excessive thirst, dry skin, and in some cases, patients present with elevated liver enzymes, indicating liver toxicity. Overall, about 20 to 25% of patients taking tolvaptan discontinue the drug. So this really has motivated our lab to come up with an alternative therapy for this disease, one that is more efficacious. Can we slow cyst growth to a greater extent than the standard tolvaptan, and then two, can we or get rid of some of these side effects involved with tolvaptan therapy? And this brings us to designing nanomedicines for the kidney. As we all know, the kidney is a really important organ in our body. It's responsible for filtering blood, removing metabolic waste products, among many other things. And the kidney is comprised of fundamental units called the nephron, which themselves are comprised of many segments, including the glomerulus, proximal tubules, loop of Henle, distal tubule, and a collecting duct system, all which play various or different roles in filtration and also have been implicated in different diseases. However, when we're designing nanomedicines for renal targeting, we're really looking at the glomerular filtration barrier. The GFB is comprised of an endothelial cell layer, a basement membrane, and podocytes, along with a glycocalyx. And this filtration barrier really prevents large macromolecules from crossing into the filtrate and being urinated out. The problem with many traditional nanoparticles is if we were to take them as is, they are very large, above 60 nanometers in size, which prevents them from crossing the GFB and entering the filtrate. However, if we make our nanoparticles too small, they easily pass through this GFB and we end up urinating those particles out. So our lab has really focused on designing nanomedicines that have a range of around 10 to 20 nanometers that are able to cross this GFB, not be excreted as quickly, and can use specific targeting ligands or targeting moieties to target specific cells on the apical surface of the tubules. One of these kidney targeting peptides is notated the KKEE3 3-repeat K peptide, which has been found to bind to megalin, which is expressed on proximal tubule cells. And in this image here, we're looking at blue, which is DAPI, which is going to stain the nucleus. Red is Cy5 tagged KKEE3K peptide. And then green is megalin, which is going to highlight the brush border of proximal tubule cells. And this image is highlighting that there's a lot of this K3 peptide around the proximal tubules, making it a really great targeting peptide for promoting the distribution of our nanoparticles on these proximal tubule cells. To actually design this kidney targeting nanoparticle, we use a platform called the peptide amplifier micelle. These are composed of monomers having a DSPE lipid, which is this hydrophobic region here, which can be connected to polyethylene glycol, or PEG in short, which is very common on almost all nanoparticle formulations. That's going to prevent the opsonization. It's going to increase the circulation time of our nanoparticles. We don't want immune cells just taking up nanoparticles. We want our nanoparticles to be able to distribute through the body and reach their target cell. And furthermore, these pegylated lipids can be functionalized with different moieties. In this case, we chose a Cy7 fluorochrome to enable the in vivo and in vitro tracking of our nanoparticles so we can see where that is.
Hi, Joshua.
Yeah.
Sorry, I have a question. My name is Dario Limas. I'm a faculty at Brigham and Women's Hospital, the renal division here. The question is, what you're showing there is megalin proximal tubule. Do you know if essentially that how can you discriminate between transcytosis? Essentially, this is like peritubular secretion into the lumen or inside the cells, the PT in the epithelial cells versus accumulation in the glomerulus. In other words, if you had a way to look at these particles over time in terms of biodistribution and see if they are retained also in the glomerulus. Just the previous slide you showed, we discussed the GFB, and I was wondering if, when you're discussing this nanoparticle now, you're supposing that they went through the Bowman's capsule and then they accumulated in the PT, or if they went directly through the PTs. In other words, if you looked at the glomerulus for these guys to be accumulated there or not. I haven't seen the size. You haven't mentioned that, and maybe I should have waited, but I just got a lot.
No, that's a great question. So the question is like whether or not we think these nanoparticles are crossing that GFB, crossing the cat and entering the tubular lumen and then binding.
Basically, right. Yeah.
Yeah, that is what we're hypothesizing. It's very hard to look at that, especially using the methods that we have, like through like confocal IHC. But that's what we're hypothesizing. Yes, is that it's crossing and then binding to that apical surface on PT cells.
I'll just
How
add
big are these guys?
actually, I'll just add one more thing is that I'm not sure Josh saw this data, but we also did intravital imaging, real-time imaging. And so you see the particles actually crossing the GFB and then going into the tubules. So that's actually published in our PNAS Nexus paper earlier this year in 2024. Yeah.
Oh, cool. And you know what percentage?
Actually.
Yeah, that's great. That's awesome. I'll look it up. I was wondering what percentage you get in terms of, and again, I'm not trying to pick too much. I'd rather leave the talk ongoing. But if you guys have methods to determine what percentage is being retained in the glomerulus versus what percentage in the tubule, this is particularly because I have an interest in delivering things to the glomerulus.
We have a glomerular targeting project, and that has things that are targeting the glomerulus, whereas this is actually small enough to pass through, and so one of the ways that you can do the glomerulus is make them a little bit bigger and then have moieties that it can target the glomerulus, whereas ours are able to pass through. And in terms of percentage, we actually don't see our particles like designed this way at the glomerulus. They all pass. And they pass, and Josh is going to show this a little bit later, but this is a great point that it can either do, GFB crossing, or it could also do it from circulation too. We've done like these inhibitory drugs, which Josh will talk about in a little bit, basolateral targeting as well. So that we actually did quantify. I don't remember the exact numbers, but I'll put the paper in the link or in the chat. Yeah.
Great. Thanks so much, guys. Sorry for interrupting.
Oh, great question. Thank you.
Since you paused, I just wanted to interject. There's a question in the chat that you might be able to quickly answer as well. It's how did you determine the 10 to 50 nanometer nanoparticle size was most ideal to cross the GFB to deliver the glomerulus and then PT?
Yeah, sure. Actually, it's really 10 to 20, I think is what Josh said. 50 is too big. They usually nanoparticles, just in general, when we just kind of broadly say nanoparticles, they usually get into the liver because they're kind of the right size for like viral kind of recognition by our immune system. And our immune system has a system called the reticular endothelial system. And it basically means macrophages look at nanoparticles, they take them and they go to the liver and the spleen and they degrade them. But when you make them just small enough where they can get filtered through the kidneys, we found that about 10 earlier studies where they were testing gold nanoparticles and metallic nanoparticles were about 6 nanometers. They actually went through and they would get almost 100% clear through the urine. But we decided that our softer organic nanoparticles on 10 to 20 nanometers, they're able to kind of wedge through that GFB, but then they have targeting moiety. So number one, we've got what we call a nanomedicine passive targeting using a physiological process. So filtration to get to the kidneys. And then part two is active targeting, where you have the active ligands that can then bind to a specific region after it's gotten to the ballpark.
Thank you. Is there any more questions? Okay, great. So yeah, when you have this pegylated lipid that we can conjugate to this KKEE3K, this targeting peptide, and you mix these two monomers under aqueous conditions, you form these kidney targeting micelles. And these micelles are around 12 nanometers in size, and we've shown that through dynamic light scattering, DLS. And in this case, I'm showing a transmission electron micrograph of highlighting their spherical morphology, and they're monodisperse in size. Their size isn't varying too much. And next, we wanted to test the biodistribution of these kidney targeting nanoparticles. And to do that, we take a Cy7 tagged micelle and inject them through the tail vein of wild type mice. And then after 24 hours, we can harvest their organs and do ex vivo organ imaging to look at where the Cy7 is, where our Cy7 micelles are. And KM are these kidney targeting micelles. Non-targeted, or NT, are the non-targeted micelles. They do not have that K3 peptide on their surface. Both KM and NT particles demonstrate some liver uptake. As to be expected, most nanoparticles do this. It's a very common phenomenon in nanomedicine. However, through the incorporation of the kidney targeting peptide in KM, we see significantly higher kidney accumulation relative to micelles without this targeting peptide. And this really signified to us that we can increase kidney accumulation or renal targeting of these small nanoparticles through the inclusion of this K3, this megalin targeting peptide. And really excited us moving forward. But on the other hand, on the other side of that, just because we're targeting the kidney, we want to ensure that we're not causing any damage to the kidney as well. So to look at that, the safety profile after a single administration, we looked at the blood urea nitrogen and serum creatinine, which are markers of kidney function and health, and saw that there is no real significant difference in these markers relative to mice that received IV PBS injection. And then also keeping safety in mind, we also looked at liver morphology. So we took liver sections and H&E stained them, and we saw that there was no significant tissue morphological differences in the KM, NT, or PBS treated mice, signifying to us that we have this kidney targeting micelle. It's able to get to the kidney. It's not harming the kidney, and it does not seem to be harming the liver at all. And in moving forward with this, we wanted to add a therapeutic to our micelle. So at this point, we only have this kidney targeting micelle platform, and then we chose metformin. So metformin is an AMPK activator, which has been shown to inhibit mTOR and also inhibit chloride secretion into the cysts. Both of these pathways are upregulated in ADPKD. And furthermore, metformin is currently in phase 3 trials for PKD. However, a lot of the preclinical models using metformin show very low efficacy. That is, that metformin isn't really great in its free form at slowing cyst growth in many mouse models, and also comes with many side effects like hypoglycemia and lactic acidosis at the doses needed to slow cyst growth. So all this together really motivated us to load this drug, because if we can increase the amount of metformin going into the kidney, we might be able to slow cyst growth via that way. To actually load metformin into our nanoparticles, we conjugated the amine on metformin to DSPE-PEG-2000, that same pegylated lipid as before, this time just functionalized with NHS. And this resulting metformin amphiphile can then be mixed with that kidney targeting amphiphile, that DSPE-PEG-2000 KKEE3K. This will give us these spherical KM metformin loaded nanoparticles, which that kidney targeted nanoparticles loaded with metformin. We wanted to confirm that the metformin was indeed covalently linked to our particles and wasn't just floating in solution. And to do that, we looked at the drug release over time. And looking at these black squares, we incubated this KM met without protease, which showed no metformin release through UV vis. And however, in the black triangles, after we incubated the KM mets with protease, we see significant release around 30% after just 6 hours, which is confirming that the release of metformin relies on the protease, and that our metformin is successfully incorporated within our kidney targeting nanoparticle. We then wanted to confirm that the metformin in this particle was actually going to slow cyst growth in vitro. So we took model cells of ADPKD. These are proximal tubule cells without a PKD1, which is the gene responsible for cystogenesis in ADPKD, and plated them on a basement membrane, and they will spontaneously form cysts. And then we treated them with various nanoformulations. And in this case, we see that the KM-MET, the kidney targeting micelle with metformin, slowed the cyst growth at day 10, and these cysts were around 5 microns, whereas free metformin, the cysts were around 10 microns, and then just kidney targeting micelles or PBS treated cysts were somewhere between 12 and 14 microns. So altogether, this is really highlighting that our metformin is successfully loaded into our kidney targeting nanoparticles, and that the metformin in these particles are acting in an efficacious manner to slow cyst growth in vitro. And now we're going to go back to that motivation and design process where ADPKD is a chronic disease. We don't want to intravenously administer multiple doses of our nanoparticle formulation, either biweekly or weekly, is that's going to limit patient adherence to our therapy. And we're going to end up running into that same problem as many therapies out there do, including tolvaptan therapy with a high discontinuation rate. So with that being said, we wanted to make our kidney targeting micelle platform orally bioavailable, and we chose to do that by using chitosan. Chitosan is already FDA approved polymer for biomaterials. It's also found in many food additives and is also used for wound dressings, so it's a great candidate. And to load our kidney targeting nanoparticles with metformin into chitosan particles, we just mix chitosan solution with an anionic crosslinker, and through ionic gelation, we have this taxi system, in which this chitosan particle can then be used to shuttle the kidney targeting micelle into the bloodstream through oral gavage. To confirm that our particles are actually encapsulated within the chitosan, we looked at their size profiles through dynamic light scattering. In panel B, these are just the KM-MET micelles that are around 10 nanometers. The chitosan particles alone are around 100 nanometers in size. And if you simply mix the kidney metformin micelles with chitosan particles, you get 2 distinct size populations, one at 10 and one at 100. However, when you load the KM-MET into the chitosan particle through ionic gelation, you get one size population at a couple hundred nanometers in size, which is also confirmed through transmission electron microscopy. So this all confirms that we're able to load the first nanoparticle with metformin into the chitosan particle for oral delivery. Chitosan is stable in acidic pH, which makes it a great candidate for encapsulating nanoformulations for increasing their oral bioavailability. And we just tested that through cumulative release or release of our micelle. So in this dotted line, we have the chitosan particles with the kidney targeting metformin micelles at a low pH, that of the stomach. And we see a very low release of micelles, around 25% after several hours. However, when you incubate the chitosan full nano formulation at a much more neutral pH, much closer to that of the small intestine, which is our target tissue of micelle release, we see 50% release at around 3 hours, which is really great. This is really exciting, showing that our chitosan particle is able to not only encapsulate our initial metformin nanoparticle, but also release it at a target site. We also wanted to confirm that the metformin in the chitosan KM-MET nanoformulation is still functional. That is, the metformin is actually being released at the into the cell and acting on AMPK. And to do that, we looked at the amount of phosphorylated AMPK over the total AMPK using an ELISA. And we saw that indeed the chitosan metformin particle was able to significantly increase this ratio relative to just chitosan particles or PBS treated cells alone. Of course, we wanted to look at where our nanoparticles are going in the body through oral administration. So we've already shown that the kidney nanoparticles can go to the kidneys through IV administration, but now we're testing that in this chitosan loaded formulation through oral gavage. And to do that, we have wild type mice that are orally gavaged with these nano formulations, and they're tagged with rhotamine B. And after 24 hours, we can look at where they are in the body. So the first thing that we noticed is that the formulations with chitosan, they have significantly more liver and kidney micelle accumulation relative to formulations without chitosan, indicating to us that there's more of the chitosan loaded particles are able to enter the bloodstream. And then the second thing that we noticed is that the KM, the kidney targeting micelle in the chitosan, had significantly higher kidney accumulation than the non-targeted micelles in the chitosan formulation. And this is quantified on the right here, or around 30% of the micelle signal at 24 hours is in the kidney, in this kidney targeting micelle group, relative to these non-targeting micelles. And so this was great. We have this orally bioavailable nano formulation that can deliver metformin to the kidneys, but how does this actually hold up in ADPKD mouse model? So this mouse model really relies on doxycycline, which deletes an exon in PKD1, which is responsible for cystogenesis in ADPKD. And then starting on P30, these mice are orally gavaged once every 3 days with our full nano formulation. And the first thing we can look at is the kidney to body weight as a ratio. So as the severity of ADPKD increases, the kidneys enlarge. Thus, the higher the kidney to body weight ratio, the more severe the disease. For instance, healthy mice have a kidney to body weight ratio of less than 2% on average. So mice without treatment or just kidney targeting micelles with chitosan particles, no metformin, have a kidney weight to body weight of 5%. However, the kidney targeting micelles in chitosan with metformin have a much lower kidney weight to body weight ratio, indicating to us that their kidneys are much, much smaller than diseased mice and that of even free metformin treated mice. We also looked at the cystic index, which is the area of the cystic area in the kidneys, and also saw this similar trend where this full nano formulation, the kidney targeting micelle in chitosan with metformin, significantly decreased cystic index relative to free metformin and kidney targeting micelle in chitosan without metformin. And this is also seen in H&E stained sections of the kidneys. They're much smaller and much less cystic than no treatment or free metformin treated mice. And so far, we're able to design this kidney targeting nanoparticle that can be loaded with metformin, and then we further loaded that into a chitosan particle to allow for oral delivery of our therapy. And all of that together was able to alleviate cyst growth in an ADPKD mouse model. And this really prompted our lab to design other kidney targeting nanoparticles for other purposes. So going back on what I was saying earlier, in the question also was that our K3, that proximal tubular targeting peptide amphiphile micelle, was crossing this GFP and binding to the megalin receptor on the apical side of PT cells. However, in ADPKD, the cysts may totally detach from the tubule system. They may become totally separate. Thus, the only thing allowing our micelles to target these cyst lining cells is this basolateral surface. And to really target this basolateral surface, we took the same peptide amphiphile micelle platform, and instead of incorporating this KKEE3K peptide, as we previously did, we integrated this integrin targeting RGD peptide that has been previously found in the literature to bind to this basolateral surface of tubule cells in vitro. We can then also mix that with the Cy7 labeled pegylated lipid to form these RGD micelles. And then to really look at how our nanoparticles are being taken up into the kidney, we performed this experiment with probenecid, which is going to inhibit the peritubular transport of our nanoparticles. So we administered probenecid 30 minutes before micelle injection, injected our mice with micelles, performed a second probenecid oral gavage, and then 6 hours after that micelle injection, looked at the biodistribution or the kidney accumulation of our nanoparticles. So this RGD micelle without probenecid displayed high renal targeting, high kidney accumulation. However, when we injected the RGD micelle after probenecid administration, we see significantly less kidney accumulation. And this is something that we do not see with a non-targeted micelle. Again, this non-targeted micelle does not have this integrin targeting peptide, and we don't see this dependence on peritubular transport. So this really prompted us to conclude that a large majority of our peptide amplifier micelles are indeed crossing the GFP and getting to tubular cells via that manner. But there seems to be, at least with this RGD micelle, a significant percentage of kidney accumulation that is coming from this basolateral targeting. We then wanted to load these basolateral targets with small molecule drugs, small molecule inhibitors. And we chose 4 small molecule drugs, namely bardoxolone methyl, octreotide, salicylate, and pravastatin. All 4 of these have been either in or are in trials for ADPKD, but have seemed to be limited by off-target toxicity or have low efficacy as monotherapies. And we can very easily load these drugs into our micelles. For instance, when we're just loading hydrophobic drugs, we can simply mix the RGD peptide amplifier with the lipid tail, another lipid tail, such as the Cy7 peptide amplifier with the hydrophobic drugs. And under aqueous conditions, the hydrophobic nature of the hydrophobic drugs will want to interact with the hydrophobic tails of the lipids, and they'll kind of compact into the interior of their micelle. However, the only hydrophilic drug in this paper was pravastatin, and we can easily conjugate that onto our micelle as well, very similar to what we did with metformin. So in this case, we took pravastatin, which is hydrophilic, and connected it directly to a lipid tail through a peptide bond. Thus, the drug is presented on the surface of our nanoparticle. And altogether, we were really interested in combination therapy. So how different combinations of drugs, of these 4 drugs, are going to slow cyst growth in ADPKD, and whether or not we can limit the off-target toxicity associated with these drugs and improve their efficacy. To test their efficacy, we use this ADPKD rapid model in which the same genotype mice as previously used in that chitosan work was used here. These mice were injected with doxycycline on P10 to induce rapid cyst growth, and then IP injected once every 3 days until P21. And the readout that we were most interested in was this kidney weight to body weight ratio. And we see that most of the free drugs, either as monotherapies or as combination therapies, did not provide a significant decrease in kidney to body weight as a ratio. However, when we loaded these into our either non-targeted or RGD targeted nanoparticles, we saw significant reductions in that kidney to total body weight ratio, indicating that our micelles are facilitating or enhancing the efficacy of these drugs as a combination therapy. And one of the ones that we're really interested in, we saw a really great decrease in the kidney to body weight ratio, is this bardoxolone methyl and octreotide group, where we can clearly see through the H&E stained kidney sections that the kidneys are much smaller than the free combination therapy. And also there's a much more dense cortex in these kidneys relative to the free combination therapy, which was very promising. And we were very excited with this work. And so now we're going to take a step in a different direction. So we have these kidney targeting micelles that we had metformin, put them through an oral delivery system. We were able to slow cyst growth in a mouse model of ADPKD. And now we're able to design these basolateral targeting nanoparticles that can deliver different drugs, the hydrophobic drugs, in combination therapy to slow cyst growth. But something our lab has more recently been involved in is just using RNA therapies for alleviating kidney diseases. So very briefly, some typical RNA therapies include RNA interference, where siRNA or antisense oligos can essentially either lead to target mRNA cleavage and degradation, or we can deliver mRNA and replace protein that was mutated in the target cell. However, these nucleic acid therapies typically have a lot of pitfalls associated with them. So very specifically for RNAi, unless the RNA backbone is modified, it will typically be degraded in circulation and won't be able to cross the cell membrane. And when it's modified, you only have a modified RNA. It'll be taken up in a non-targeted fashion. It'll be distributed through a lot of tissues. And in the kidney, more recent work has shown that they'll be uptaken almost exclusively in proximal tubule cells. And for mRNA protein replacement, mRNA is very susceptible to nuclease degradation and won't be able to cross the cell membrane, so it has very poor cell uptake alone. Thus, this is why both of these therapies are really promising candidates for nanomedicine, for developing nanomedicine. And we'll switch gears a little bit, going from ADPKD into our research on clear cell renal cell carcinoma, where this is a kidney cancer which has many FDA-approved agents, including belzutifan, which really inspired us. Belzutifan is a HIF-2 alpha inhibitor, and like most cancer therapies, comes with a slew of side effects, including muscle pain, increased liver enzymes, and in this case, decreased hemoglobin. And to really get an idea of what is happening in a large majority of CCRCC cases, we'll look at this HIF-2 alpha pathway, where HIF-2 alpha is typically hydroxylated in complexes with VHL protein, and this will undergo HIF-2 alpha degradation. However, around 80% of CCRCC cases are caused by this mutation in the VHL gene, where there's no complexing with the HIF-2 alpha with VHL, meaning that there's excess HIF-2 alpha, which complexes with HIF-1 beta to upregulate hypoxia responsive genes, which ultimately promote the formation of large tumors in the kidney. And this is very commonly characterized as high metastasis, proliferation, and angiogenesis. With the thought of belzutifan being that if they can inhibit HIF-2 alpha, they can then turn off a lot of these upregulated hypoxia response genes and slow the growth of the tumor. To design our nanoparticle to go to this tumor, we use previous research that identified CD70 as a cell surface marker that is highly expressed on the tumors in clear cell renal cell carcinoma. And also previous research has found its targeting partner, the CD27 peptide. And we were able to, as I previously described, conjugate this DSPE PEG 2000 with this CD27 peptide, which is going to bind CD70. We can then mix this targeting peptide amphiphile with DSPE PEG that is conjugated to HIF-2 alpha siRNA. And then also we can add and mix in other in vitro tracking moieties, such as the pegylated lipid with Cy7 or FIPSI. We first explored whether or not the micelle is actually targeting primary CCRCC cells in vitro. And this top row is the CD27 micelle, this targeted micelle, which demonstrated high binding to these cells in relation to scrambled CD27. This is the same amino acid composition, just a scrambled sequence, which showed significantly less binding to these primary cells. In addition, we blocked CD70 with free CD27 peptide and saw that there was a sharp decrease in micelle binding to these cells in vitro. And altogether, we concluded from this that we have this CD70 targeting micelle that binds to these CCRCC patient cells to a high degree. We then wanted to just look at some in vitro hallmarks of CCRC. First, we wanted to ensure that our micelles are able to deliver the HIF2 alpha siRNA to the cells, and that siRNA actually act on its target. And we did this by using RT-qPCR, looking at HIF2 alpha mRNA, in which HIF2 alpha CD27 PAMs have around 60% HIF2 alpha knockdown. And this is compared to scrambled HIF2 alpha or PBS treated cells, which show no knockdown of the gene. We also looked at the proliferation of HUVEC cells because inhibiting HIF2 alpha has been associated with decreased proliferation. We analyzed the impact of knocking down this gene using our micelles on proliferation in these cells and saw that it decreased by around 40%. And also we looked at migration, which is highly intertwined with HIF2 alpha expression through a scratch assay, and saw a significant decrease in wound closure, which is indicative of migration in this HIF2 alpha siRNA CD27 PAM treated group relative to free siRNA, scrambled non-targeted micelles carrying HIF2 alpha siRNA, and PBS. And from all that work, we really have a large repertoire of things that we can do with our peptide amplifier platform. We can load various hydrophobic and hydrophilic drugs into these micelles, and we can also have been loading small nucleic acids for gene knockdown and microRNA delivery to renal cells. And with all that being said, our lab has really focused on designing and developing these small kidney targeting nanoparticles that can be loaded with various cargo. The therapeutics loaded into these nanoparticles have been able to slow the progression of ADPKD more so than their free drug counterparts. And current work by our lab is really excited about investigating cell-specific targeting of our nanoparticles, whether that be proximal tubular targeting versus distal tubular targeting versus targeting renal macrophages, and exploring that for different diseases and different use cases. And with all that being said, I just want to thank everyone for their time, and I'm happy to answer any questions.
Thank you, Joshua, for that presentation. That was fantastic.